Good afternoon, everyone. I want to go ahead and welcome you to UCSF Family and Community Medicine Grand Rounds today. We are excited to have a wonderful speaker and a wonderful presentation for you. The title of today's talk is San Francisco's Approach to Improving Behavioral Health Services. And our presenter will be Dr. Hilary Kunins, who I'm very excited to welcome. But before we get started, I just want to go ahead and do a few of the usual housekeeping announcements. For all of you who's just joined us, this session is being recorded. If you want to go back and watch this session or see what else has been presented on UCSF Family Medicine Grand Rounds, you can find them on our website. They're all uploaded there. There's some really great sessions. If you have feedback today for our presenters or just suggestions for other grand rounds, we have an evaluation form that we'll send out electronically. At the end, we encourage you to please fill it out. Your suggestions matter to us. Or if you have suggestions, ideas of future speakers to recruit, my name is Margot Benner. Please reach out to me at UCSF. As always, I want to thank our tech team. Today we have John Tess helping us, and we have Roy Johnston helping us from afar, but he's been called out of the building on a fire drill, I kid you not, that just started for all of you at Parnassus. You're probably aware of that. So we will hopefully welcome Roy back soon. Today's session is going to be exciting, informative, and hopefully interactive. So I'd encourage you to please enter your questions and comments in the Q&A, and we will have time with Dr. Kunins at the end to share your thoughts and comments and answer some of your questions. So today's session is on San Francisco's approach to improving behavioral health services. As we navigate multiple intersecting public health crises, including the COVID-19 pandemic, systemic racism, homelessness, and the opioid, fentanyl overdose epidemic, there's really an unprecedented need for mental health and substance use care in the city of San Francisco, and I would argue everywhere. Today, Dr. Kunins will share how the San Francisco Department of Public Health is growing and transforming behavioral health services to expand access to timely, equitable, and well-coordinated care. Dr. Kunins is the Director of Behavioral Health Services and Mental Health San Francisco at the San Francisco Department of Public Health. In 2021, she joined the DPH from New York City Department of Public Health and Mental Hygiene, where she served as the Executive Deputy Commissioner of Mental Hygiene from 2019 to 2021, and as the Assistant Commissioner for the Bureau of Alcohol and Drug Use from 2012 to 2019. In this role, Dr. Kunins led the reimagining of New York City's public health approach to substance use and served as the lead for Mayor Bill de Blasio's $60 million Healing NYC initiative to address the overdose epidemic. She has dedicated her career to creating health equity through science-based public health and healthcare programs and policy for people with behavioral health concerns, including substance use disorders and serious mental illness. Dr. Kunins received her MPH and MD from Columbia University and her Master's in Clinical Research from the Einstein College of Medicine. She completed her primary care internal medicine residency at Montefiore Albert Einstein, graduated the same year as me. We just figured that out. She is a primary care doctor at heart. She's a former residency program director and a true primary care practitioner who truly understands the impact of mental health and the needs of our patients and their wellness. I am delighted to welcome Dr. Kunins. Thank you.
Thanks so much, Dr. Benner. It's a real pleasure to be with all of you and to have been invited. Thank you. I feel very honored. As you just heard, I'm going to try to share my screen for my talk. I'm really excited to be here to tell you about San Francisco's Public Health Department Division of Behavioral Health Services, what we have been up to, and how we are approaching the work that we're doing to improve our behavioral health safety net system, how we are thinking about improving health outcomes for people with serious substance use disorders and serious mental illness. Margot asked me when we were preparing for this talk to give you a little bit more flavor about how I, as a primary care trained doctor, ended up in this sort of role. Like those of you who are in residency or beyond, I set a career path wanting to work as a primary care doctor in communities, either indigent or underserved communities, and was attracted to training in the Bronx, where my family hails from originally, in order to really work in what is in many ways the poorest borough of New York City, and in an area where real social drivers, social determinants of health lead to amongst the poorest health outcomes for people, particularly in the South Bronx. That has nothing to do with actual genetics or biomedical conditions, but really around things that all of you already know and care about and are working to improve, things like racism, things like poverty, consequences of long-standing redlining, and so forth. Despite my intent, I ended up following residency working indeed in the South Bronx, but in a methadone maintenance program where I had really still to this day, the best clinical job of my career. I served as the medical director of a small methadone maintenance clinic in which we were charged at the time with setting up co-located primary care, along with improving care for HIV and hepatitis C at the time, really without any curative treatment. And it was there that I experienced a lot of the benefits of primary care, longitudinal care, working intimately with a relatively small panel of patients, having the chance to care for them both in the outpatient setting, and at the time we cared for patients when they were hospitalized, and understanding profoundly the consequences of substance use, both at the policy level, the ways in which people who use drugs and have addiction experience criminalization and experience the consequences of having been incarcerated or involved with the criminal legal system, where I saw with small multidisciplinary teams how their health could be improved, and with policies that allowed us to both finance and implement integrated physical and behavioral health care. I also got the pleasure of being sort of a small town doc in the middle of a very big city, because the South Bronx is quite intimate. Had the chance of walking down the street, going into the deli, running into my patients, their family members. And it was really, really many of the pleasures of primary care, with the additional benefit of working with people around their addiction and seeing them over time. Fast forward a great number of years, I ended up, as you just heard, working in public health, first focused specifically on substance use, which I had been long working in, but really subsequently expanding my both interests and portfolios to work on the mental health side of the house, which we know should not be a different side of the house, but because of many, many factors, including funding, those universes are often, but ought not be siloed. So with that, I wanted to sort of tee this presentation up by just describing a little bit about the structure of how and why we have the behavioral health safety net in San Francisco. Similar to counties all across the country, safety net behavioral health is funded at many different levels of our government, including the federal, state, and local levels. So here in San Francisco, the way we pay for safety net behavioral health care in San Francisco is through those mechanisms, through local San Francisco taxes. For those of you who live here, you are helping to pay for them. through state and federal funding through the Medi-Cal or Medicaid program, and through what are called block grant dollars that are passed on by the federal government, SAMHSA specifically, through to the state. And this is the way behavioral health care is organized in various degrees of funding all across the country. And in that context, at the county level, there is usually a behavioral health director who is responsible for helping to architect how those dollars get spent locally. There are different versions of this across the country, how much state versus county control there is. There is in many jurisdictions across the country, the city and the county are not coincidental. So there is a county authority that is allocating funds and prioritizing how resources get spent. Here in San Francisco, I think importantly from a governance point of view, the city and the county are coincidental. And so the county funding really is equivalent to the city funding. So I think, as all of you will know, Medi-Cal is California's public health program for people who have low incomes. And the Medi-Cal program in California provides coverage for the behavioral health care of people experiencing mild, moderate, or severe mental health and substance use disorders. Importantly, and I think for those of you working in primary care, and I know there are many of you, the county behavioral health, that is San Francisco's Department of Public Health, behavioral health division, is responsible for the payment of and the delivery of care for the needs of people with moderate to severe behavioral health disorders. The so-called mainstream managed care plan, that is, in our case, San Francisco Health Plan, and if you are working in different counties, this is organized all a little bit differently. Those managed care plans are responsible for mild to moderate behavioral health care disorders. So for example, in my dear colleague, Dr. Hallie Hammer, who heads up ambulatory care for the Department of Public Health, in the San Francisco DPH clinics, the care of behavioral health for people with mild to moderate illness is a charge of in primary care settings with the goal of integration. So this is just a little bit of context about why and how the Division of Behavioral Health does what it does and seeks and why we focus on the population that we do. So this is a slide that remains a bit of work in progress as I continue to get settled in and develop the work that we do. So our mission in the Division of Behavioral Health is to promote recovery, well-being, and participation in community, as well as prevent death, illness, and suffering for San Franciscans with or at risk for a mental health or serious substance use challenge. Our goals are to improve access and effectiveness of mental health and substance use treatment and recovery services. We are also aiming to increase public awareness about where and how to get help for these challenges. And very specifically, we are aiming to expand proactive and low threshold interventions that reduce risky behaviors and prevent illness. There are a number of kind of external forces that are propelling our work, some of which predate me and some of which are very much in progress. These are sort of the three big ones that I'll name today, and there are certainly other drivers. First is a large taxpayer initiative and local piece of legislation called Mental Health SF, and this is a charge to really do serious reform of the way we deliver behavioral health care, and I'll get into more details. What has been enabled also a great number of programming in San Francisco is something called Prop C. Prop C is a local San Francisco taxpayer-backed initiative to create more of a funding stream for the care and housing of people experiencing homelessness. The majority of this funding goes to housing and improvements in retention and prevention and housing people with experiencing homelessness. And some of that money has been allocated to the Department to Behavioral Health, to the Department of Public Health under Mental Health San Francisco and more. And then finally, which I'm going to touch least on, is something called CalAIM. CalAIM is a very important and large Medi-Cal reform endeavor to really change what we do on the behavioral health side, from how we are allowed to deliver care in the Medi-Cal program, how we can bill and derive revenue in the Medi-Cal program. The program also incorporates a large number of new services into what is Medi-Cal eligible, things like community supports, things like enhanced care management, which for us in specialty behavioral health and for those of you in primary care will touch you in a great number of ways. And the city and the Department of Public Health as a whole is very large, involved with the state and with each other, as well as the San Francisco kind of mainstream health plan in thinking through and implementing the many features and requirements of CalAIM. So focusing now on our division and what we do, we have a budget of approximately $600 million. We are the largest provider of mental health, substance use prevention, early intervention, and treatment services in San Francisco. We do this through both direct service delivery of approximately 700 staff members, along with contracting for services, perhaps some of the organizations you work for, a total of 80 contracting partners. This enables us to deliver clinical services, and in last year, we delivered formal treatment services to approximately 21,000 people across 200 plus clinical care sites in the city. We also touch a great number of additional folks through prevention and what we call early intervention services, as many as 80 or 100,000 additional people per year. A big push, as I had mentioned, is we are really aiming to amplify behavioral health services through primary care clinics, through collaboration with our ambulatory care division, and in the community delivered by street teams. You can see on the right, the graphic on the right part of your slide, you can see the large number of ways we divide up these services into different groupings, some of which are age-based, some of which are topically based. And you can see that we have primary care, which is in sort of a pink, which is a collaborating site where we work and aim to integrate care. Next slide. What was probably mysterious to me, was mysterious to me when I was a primary care doctor, and is now not mysterious, is the great continuum of care that happens in specialty behavioral health. And I put up this slide to really show you our continuum of care, and particularly to highlight sort of the great depth to this care and the great variety of kinds of care. We fund some of our community-based prevention, early intervention, and outreach work. These are often interventions and programs that happen outside of the clinical delivery system, and rather through social service agencies, economic development agencies, sometimes primary care-based agencies. We also, as I've been mentioning, are aiming to conduct more work on the street and in very low threshold settings and through low threshold supports. Things like in drop-in centers or through our street-based teams. Outpatient behavioral health treatment, whether substance use or mental health, is probably the area that, for those of you working in primary care, is probably most familiar. it looks so awful like primary care in the sense that patients come in, they see a provider. In our case, it's not necessarily an MD or a nurse, but often a provider of psychosocial care, like a marriage and family therapist, a social worker, another kind of a counselor, a licensed substance use counselor, and so forth. Many of the modalities in outpatient treatment are different than what happens in primary care, much more typically group supports and group counseling. Peers are likely more routinely incorporated into the care team. Moving down the continuum in intensity, we provide also a great deal of residential care and treatment, things like residential mental health treatment, residential substance use treatment. This is often the place that people automatically think of the care being delivered in residential or overnight settings. We also have crisis programs, including our psychiatric emergency department at Zuckerberg, as well as mobile crisis, which is not a care modality that I was particularly familiar with until moving into the specialty behavioral health systems. Hospitalizations and involuntary treatment is also part of our care continuum. We, of course, as well as with locked facilities, aim to keep this as a last resort, aiming to have this be an avoidable and preventable need, but it is indeed part of what we do. You can see on the lower left of your slide, there are many points of entry into our systems of care, and we are working to make these more understandable to providers across the system. That's partly why I'm very happy to be speaking with all of you, and to make it more both comprehensible and accessible. I see that I am going slower, of course, than I intended, and so I'm going to skip over this slide. I want to highlight how vital it is for us, and you all will know this, is to aim to deliver culturally congruent services, particularly to address racial disparities. We are doing a number of both pilot and innovative programs. You can see some of them here. I just want to mention first our the one that is the top intervention. We are aiming and have launched it sort of slowly to test and evaluate culturally responsive behavioral health interventions for Black African American clients at 4 of our DPH run clinics. We're very excited by that program and really looking forward to seeing how effective it is in meeting the needs of our Black African American patients, as well as our ability to attract more people into care who might need it. We're also very excited about the bottom new program, which is an equity-based maternal health RFP, that request for proposal, meaning we are soliciting applications, came out just now. This is in partnership with our colleagues in ambulatory care to fund 4 community-based organizations to support Black African American maternal health and the health of birthing people, to co-deliver mental health care in the peripartum period. Let me turn now to Mental Health San Francisco, which I mentioned earlier. So Mental Health San Francisco represents really a large expansion of services for San Francisco behavioral health. We are focused on expanding mental health and substance use services, particularly for people experiencing homelessness. And our work is divided into 4 domains: Office of Coordinated Care, a mental health service center, a new beds and facilities group, and our street crisis response team. I want to just speak very briefly about each of these key initiatives. First, I want to kind of quantify who this population is and where we are really focusing. Our priority population are, for the moment, are adults 18 and over experiencing homelessness and who have a serious mental illness or substance use disorder. We are also prioritizing people who are uninsured or enrolled in Medi-Cal, Healthy SF, and people who are justice involved and coming back home, reentering community. When we look at that population in terms of size, using our data systems across San Francisco, we identify approximately 19,000 people who have experienced homelessness at any time in the past year. And about 8,700 have either a serious mental illness or substance use disorder. Among these, the majority, 84%, have a substance use disorder, and about half have a serious mental illness. As you can see on the graph, there is a great overlap between the two populations, and it is really important that our services are able to address the needs of people with both these conditions, particularly when they are occurring together. We are also aiming to really develop and publish some key metrics so we know how we are doing. You can see our 11 key metrics. There are many more underneath this, which is really driving our own measurement and our public measurement of success. I'll just note some of the things that are not fully in our control, but we are very eager to measure and to advance these. The first is housing. We know we need to work across the city. This is not really a singularly DPH project, but we want to support in any way we can folks with serious mental illness and substance use disorder finding housing, particularly supportive housing. I'll jump down just to the bottom to really talk about quality of life for a moment. And we know this is sort of the holy grail of the behavioral health sector. We know from a medical point of view, we can help people take medicines, we can help people gain access to counseling and participate in counseling. But really what we want to do is support people to have a greater quality of life, helping them participate in community, gain employment, have good relationships, strong relationship with friends, family, community members. And it's hard to measure that in clinical care. And we don't have routine ways of doing that yet, but this is sort of where we are going and aspirational. So as we go, we will have these metrics up on our website, and we are still working through our ability to produce them and share them with the public. Let me make a few comments about some of the other specific domains. We're very excited about our recent launch of the Office of Coordinated Care. This office is aiming to ensure equitable and well-coordinated care for folks entering in or who might need specialty behavioral health services. We know that the systems of care we have are not well poised to help people move between levels of care, be retained in care, particularly for the people who are most in need. And so we are organizing this office through our behavioral health access programs, which is both a telephone line as well as a physical drop-in site, along with our expanding care management teams to try to achieve those goals of improving access into care, improving retention in care, and improving ability to have people step up to higher levels of care or step down to lower levels of care. We are also aware, and I'm guessing many of you who work in both the Bay Area and in San Francisco are aware that we simply do not have enough residential care and treatment locally. What we are enacting is a bed implementation plan that was derived from an optimization study conducted in 2019 before the pandemic to create approximately 400 new beds through mental health SF. So far, and this got paused and some delays during the pandemic, as well as the fact that the money was not allocated until 2021. Nonetheless, we've been able to open so far 250 beds to date. This is as of December, with additional 150 beds coming online over the next 9 to 15 months. This is available on our website, and we are really wanting to help you all, the public and other health professionals, keep track of where we're going and how much progress there has been, even if there is much more to do. Finally, to sort of much fanfare, the city launched in November of 2020 street crisis response teams, which are multidisciplinary teams intended to respond to behavioral health crises on the street in order to avert unneeded law enforcement encounters, as well as increase our ability to both de-escalate in real time behavioral health crises on the street, as well as through a dedicated follow-up team as part of the Office of Coordinated Care to do effective follow-up and linkage to care. As of this past year, SCIRT has been made fully operational with 7 teams across the city. To date, really through December, the SCIRT teams had more than 15,000 encounters, and by and large were able to resolve behavioral health crises on the scene. A minority needed a hospital transport, and a minority were able to, but a significant minority were able to be connected or transported to already existing other social or behavioral health settings. Since the subsequent launch of our follow-up team, our SCIRT Office of Coordinated Care team, that team was able to engage almost 2/3 of the clients in follow-up care, meaning they were able to reestablish longitudinal care, which is ultimately the goal of this program, both to stabilize the person and to prevent future crises. Turning just in our last bit of this talk, I want to transition to overdose and our overdose response. I think, as everyone will know, overdose deaths is a national crisis. And during the pandemic, nationwide, we saw ongoing increases in overdose mortality nationally. In San Francisco, similar to many other parts of the country, we saw a very steep rise in overdose deaths, mainly driven by fentanyl. And what you can see on this slide is, in the black dotted line, that sharp takeoff in overdose deaths from 2018 to 2019, that involving cocaine or methamphetamine or opioids. The red line just underneath the black dotted line shows deaths involving any opioid. So in 2020, the city saw more than 700 deaths due to overdose, and we actually saw a slight decline to about 600, and then in 2021, and just brand new recent data, which is, I'm realizing, not even yet on this slide, deaths declined in a preliminary analysis by the Office of the Chief Medical Examiner, just a little bit more to low 600s. So in contrast to really most parts of the country, we have seen a little bit of a decline. Nonetheless, these deaths are remain at epidemic proportions. And of particular concern is that deaths in San Francisco, similar to the patterns nationally, is there are profound racial disparities in who is dying in San Francisco of overdose. Black African Americans represent just 6% of the population in San Francisco, but represent 29% of preliminary overdose deaths in 2022 to date. And as you can see on the slide in front of you, in the graph in front of you on the left, this is true in 2021 and before. So any overdose plan and approach needs to address both the epidemic of overdose, the fact that it's being driven by fentanyl, and that there are disparities in who is dying. And in San Francisco, this is particularly among Black African Americans and those, which I did not show data on, experiencing homelessness. So we have several strategic areas in the overdose plan that we released late last year. These include our goals of increasing availability and access to the continuum of substance use services. We are aiming to strengthen community engagement and social support for people at high risk of overdose. We know that we need to take what we call a whole city approach to overdose prevention, working across sectors, both in the healthcare delivery system, the social service system and systems, as well as multiple other sectors in the city. And then finally, we need to strengthen our ability to track trends and metrics so that we can measure both our successes as well as identify areas in which we need to change our approach across the city. Let me just share with you some of our key goals over the coming years. We are aiming to reduce fatal overdoses by 15% by 2025, reduce racial disparities in fatal overdose among Black African Americans by 30% by 2025, and increase the number of people receiving medications for addiction treatment, or MAT, by 30% by 2025. And as this group likely knows, why focus on medication treatment for opioid use disorder is because it is the most effective strategy using buprenorphine or methadone to prevent overdose deaths among people with opioid use disorders. I think I missaid this already, and I think for the sake of time, and we can go back to some of these, I'm going to just move to my last, I think, 2 slides. Just as a framework by which we are thinking about overdose prevention services, we really are using the stage of change model, which you are likely to be familiar with. This is the stage of change that really influences how we think about and conduct behavior change interventions, both in healthcare delivery, social service delivery settings. We know that people who use substances, as well as want to make other health behavior change, can move along and across and back and forth a continuum that includes pre-contemplation, not thinking about making behavior change, contemplation, thinking about it, but maybe not totally ready, preparing to make a change, taking action to make a change, and then having made a behavior change in a maintenance phase. We are really trying to think about our interventions along this care continuum to prevent overdose, ranging from delivering what is often called harm reduction interventions to people who are in pre-contemplation or contemplation via overdose prevention programs, naloxone distribution, syringe access sites, low threshold counseling, and then moving into more formal treatment and structured settings for folks taking action to reduce or stop their substance use or maintain their absence from substance use in residential, outpatient treatment, medication treatment, and sober living sites. And of course, we write this continuum as if each stage is quite separate and each intervention is separate. But as you know from clinical work, this is messy and complex. People move back and forth, and no single intervention should or works with people at any sort of siloed stage of change. But we are really trying to structure and think about our interventions in this way. I'll end with some of our recent accomplishments around naloxone, and this will be one of our key outcome metrics is we know this city, San Francisco, has really been a national leader and early adopter of naloxone distribution. And in fact, while I was in New York, San Francisco was leaps and bounds over where we started in 2012 in New York. And really, we looked to San Francisco for the many innovations in overdose education through community partners, such as with the DOPE project of the Harm Reduction Coalition. But we also know, given the extent of the crisis, we need to do more and more widespread distribution to save lives. So what you can see here is our increasing naloxone distribution and overdose education in the city, with increasing naloxone starting really steeply in 2019, 2020, 2021, impressively increasing distribution during the thickest part of the pandemic. And we expect in 2022, we don't have our numbers finalized, to exceed our distribution in 2021. So this is part of the way in which we would like to measure success, with more to come. And we like to, we hope and believe that this is responsible for halting the rising deaths, part of what's halting the rise in deaths due to the fentanyl entry into the drug markets here, and despite sort of the increasing pressures of COVID. So I'm going to end sort of abruptly there. I know I covered a great deal, and I'm looking forward to having time to answer questions and have some discussion. I'm going to attempt to stop sharing my slides to do that.
I want to thank you, Hillary. That was an incredibly impactful and, for me, eye-opening presentation. I'll just speak for myself and say, as a primary care provider, I tend to see my patients as individuals in the moment. That's part of the reason I do what I do. But this really helped give me a much broader context of where the city is with this, where the communities are, and I really thank you. We have a great comment from Dr. Lee Kimberg in the chat, which I'm just going to read out loud. Lee wrote, "This is so incredibly helpful and amazing to witness how committed you are, Hillary, to a systemic approach supported by transparency and accountability. I've worked in San Francisco's safety net, DPH, for over 30 years in primary care, violence prevention, and trauma-informed care. I noticed that our systems are very adult-focused, and today's suffering children from the same forces of racism and oppression and capitalism, et cetera, are at risk for these severe adult poor health outcomes. Could you describe how the DPH is investing in preventing adverse social conditions, harm, healing, and health for children and young adolescents?" Thanks, Lee, for sending that comment. And if other people have comments or questions, please, I would encourage you to use the Q&A.
Thanks. Thanks for that question and comment. And I think, and I just, before I shift to that comment, I just want to acknowledge Margot, that, I think as clinicians, we have all been trained to take care of the person, or for the, for the family medicine among you, for the family, as kind of the unit of clinical care. And I just want to say, as a clinician, that is such vital work. And I think that partly what motivated my shift into public health is, as I contended with the many social forces, and it isn't always in our realm of influence as an individual clinician to fix all of that, and nor should you or we. And because we need the richness and the commitment and sophistication of clinical enterprise to do all of that work also. And I sort of see this as sort of an iterative partnership, and also to say that the clinicians often have enormously potent insights into the ways in which policy does and doesn't work. And so I see my work as a government official as trying to incorporate feedback from not only the delivery system, but also other folks who are recipients of policy decisions in order to help make better policy. And policy is quite blunt. It doesn't always, and maybe even often, get it right. And I think of clinical care as being sort of the pointy edge, which can be nuanced and precise. And policy is often global and has many opportunities to get it wrong, even if you were, so just to say, I see this as very much iterative. So on the children's front, Dr. Kimberg, thank you for your question. And I am now conscious I mentioned kids, except didn't mention kids in this talk, because in fact, a lot of the new initiatives have been so focused on adults and so focused on sort of handling what are the most visible challenges sort of our day, of our city. And I totally agree that to go more upstream and go more, to do more prevention work, we must get to kids and families. And I don't want to presume to speak for all of DPH, and I know there are other, including Dr. Hammer, who is listening in, are in charge of a lot of what's happening with kids in our systems of care and in our department. In my section in behavioral health, we have a really strong children, youth, and family, what we call system of care. And in that system of care, one of their focuses is both the delivery of specialty care to kids and families, as well as working across sectors with schools, and I think this was in the question, let me actually pull it up again, with other sort of child welfare, with other systems, frankly, which don't always promote kids' health, but can sort of traumatize and re-traumatize kids. And so their approach, and maybe this is a different talk, or maybe someone else from my team would be the right person to really speak about, I think, a lot of the fantastic work that they are doing. I think that there's more to do and better to do. And I'll just mention an intervention that we do in San Francisco, which when I was in primary care, and maybe this is a little too specialty oriented for much of this audience, but one other very important piece of work that behavioral health does is to intervene early after somebody has a first episode of psychosis. We know that people with serious mental illness often present with a symptom, with a psychotic break, sometimes months and years before they are effectively treated. And there is an approach that's called coordinated care, available here at UCSF through at least one or more of our contracted providers, Felton Institute, to get to young people, often transitional age youth or adolescents, with multidisciplinary coordinated care. And that care has been shown to change the trajectory of people with serious mental illness. And for those of you taking care of kids and families, just to be aware of that and to help advocate for that, whether your patient is commercially insured or publicly insured, is a very concrete intervention that can really change a person's outcomes. I know that this doesn't get fully to the broader issues, which I totally agree are critical, that Dr. Kimberg raised.
And thank you. And that really is a helpful perspective to just sort of give us the whole framework, which for me, I think is going to be one of the main things I take away from this talk. Since you were talking about trajectory, I wanted to ask you one other question about trajectory. I hear that San Francisco is in the first wave of counties that's implementing Care Court. Could you just tell us a little bit more about that and what that is and what that may mean for trajectories?
Absolutely. So thanks for that question. So for those of you who may not be aware of care courts or what that means. This is a new piece of California legislation that will be creating an assessment process for people referred to this court who might be eligible for a kind of compulsory care. These are folks who may have a serious mental illness, and very specifically in the legislation, have a psychotic disorder, but who have not been able to be stabilized through fully voluntary care. So this city, San Francisco, has signed up to be among the 7 California counties who will be first to implement. This will be done. The court has the responsibility to accept what are called petitions, to gather information supporting the petition, and then the behavioral health department, us, will be responsible for clinically assessing the situation and either sort of saying that the person is eligible based on clinical criteria or not, and then responsible to help navigate that person into care. We are very eager to also make sure we have good evaluation data to understand the impact of the program on a person's ability to stabilize and to get better. And so it's potentially represents a new opportunity to help get sort of a relatively small subset of people into care. We also know that part of our challenges, and this is really at the heart of what we are trying to do, is that we need to make our systems more accessible, more, just to use sort of language from primary care, patient-centered, friendly, meeting people's needs. And that is really kind of the prime directive, in addition to some of the very specialized programs which do look to expand our ability to get people into care who are deteriorating physically, emotionally, in community, where we have not been able to pull them into care. That can be life-saving.
Yeah, thank you. Thank you for sharing that. We have 2 more questions and not very much time, so I'm going to read them out and then hope maybe you can just give very brief answers. The first one is from Emily Mariko Sanders, who asked, based on the new programming for Black people, will there be more funding for mental health services, specifically in the Bayview, Viz Valley, and Western Edition, Potrero Hill areas?
So thanks for that question. And those parts of the city are of high priority. And one new program that I was just in a conversation about this morning that got funded in last year's budget cycle, which will be to increase services for women from the Bayview with both mental health and substance use diagnoses. We're very excited about that service. We also look for ways, and this is both within behavioral health and with our colleague departments, to expand mobile services. For example, there are opportunities to do mobile outreach and engagement, and we are looking for ways to increase that in Bayview, Viz Valley, as well as Potrero.
Thank you. I apologize, these questions are getting kind of crunched at the end because they're really important ones. I want to at least give you a chance to respond to the very last question, which is really about finding a developmentally specific model of care, behavioral health that meets the needs of adolescents, including trans young adults and adolescents, ideally. Also thinking about integration of harm reduction, meeting youth at their point of need, and really welcoming them into long-term medical and behavioral health care. Do you have thoughts about that? I'm going to let you share your thoughts on this, and then we're going to wrap up.
Sure. And I'm sorry, PCBH is, I'm looking at the question in the chat. That is
behavioral health.
Sorry?
Patient-centered behavioral health.
Patient-centered behavioral health. So
care behavioral health.
thanks. Thanks for that feedback. And I will take that back to my team. We do have a number of services for TAY youth, including we will be setting up some new residential programming for TAY youth, as well as increasing outpatient or ambulatory care for TAY youth. I think the way this questioner is framing this is absolutely consistent with how we are thinking about how we would approach this, both from a harm reduction, longitudinal behavior engagement and change point of view, but also the point of need, I like that phrasing, and trying to do to bring care to folks instead of asking them to come to us. And I will bring that back to my team, and thank you for the question. I don't have a lot more to say. I hope I have given sort of enough of a flavor of what we are up to. I love getting questions that are on people's mind because it gives me an opportunity to hear what's important to all of you, to whichever community I am speaking with, and bring this back to our teams as a way to shape our work and make sure that we are being responsive to needs in San Francisco. So thanks so much.
Hillary, I really want to thank you for a wonderful session, and there are more questions being put into the Q&A even as we speak. So I would really encourage open dialogue, reaching out to Hillary and her team who's doing amazing work. And I did misspoke, it's primary care behavioral health. Sorry, a little nervous there, but on behalf of everybody on this call and the patients that are part of our community, I just want to thank you for all of your hard work in this really important area. So thanks so much.
Thanks so much.
Bye-bye. Have a good afternoon.